Everybody, we are experiencing some technical difficulties, so please just sit tight and we will have it corrected in just a second.
Okay.
Doctor, we can see and hear you.
Okay, I can start.
Yes, thank you.
Okay. So, good evening. Sorry about the little technical glitch, but we're going to try this again. And what I want to do for you this evening, and again, welcome, is we're going to be taking a deep cleansing breath, updates in the management of our patients with chronic rhinosinusitis with nasal polyps. I'm Dr. Michael Blaiss. I'm a clinical professor at the Medical College of Georgia at Augusta University in Augusta, Georgia. And I'm also the executive medical director of the American College of Allergy, Asthma, and Immunology. These are my disclosures for this particular lecture. And I have three learning objectives that I'd like to cover with you this evening. And we'll analyze the different phenotypes and endotypes in our patients with chronic rhinosinusitis with and without nasal polyps. And it's based on what we understand thus far as the immunologic pathophysiology and its impact on disease burden. And very importantly, I'm going to summarize some of the mechanisms of action of the new and emergency targeted biologics for our patients with chronic rhinosinusitis with nasal polyps. We'll look at the efficacy and safety of the phase 3 clinical trials. And lastly, and very importantly, we'll learn how to implement shared decision making in chronic rhinosinusitis with our patients so that we can understand their values and preferences when determining whether a biologic or a surgical procedure or some other treatment is the most appropriate for their condition. So with that, we're going to start with some pre-test polling. If we could have the first question, please. The primary cytokines involved in type 2 inflammation, the most common endotype in patients with chronic rhinosinusitis with nasal polyps are 1. Interferon gamma and IL-12, 2. TNF alpha and IL-6, IL-4/13 and IL-5, and IL-17 and IL-2. So would you please submit your answer now? Our next question. Which biologic showed improvement in nasal polyp score by 2 points or better in close to half the patient population in both 24 weeks and 52 weeks? Is it benzarilumab, dupilumab, mepolizumab, or omalizumab? Submit your answer, please. Our next question: which is the most common observed treatment emergent adverse event across the clinical trials and all biologics that have been studied for chronic rhinosinusitis with nasal polyps? Is it epistaxis? Is it injection site reactions, nasal pharyngitis, or abdominal pain? Please submit your answer. And the next question: Mr. Brown, a 42-year-old male patient with severe chronic rhinosinusitis with nasal polyps, returns 12 months after endoscopic surgery complaining of persistent symptoms. And you suspect nasal polyps have regrown, as type 2 inflammation is a predictor of polyp return in greater than 50% of the cases. Disease scoring systems show some improvement, but do not meet the EUFOREA criteria for adequate response. So what does EUFOREA recommend now? Is it return to medical management, a short course of oral corticosteroids, biologic drug or revision surgery, exhalation delivery system with fluticasone, or corticosteroid-eluting implant stent? Please submit your answer. Okay, so we'll come back to those when we do the post-test polling, and I'll go over the answers with you. But first, whoops, we do have one more question. Sorry about that. Popped up. Feeling discouraged, Mr. Brown says if the nasal polyps are not going to grow back anyway, he doesn't want to go through all the expense, pain, and downtime of undergoing surgery again. Shared decision-making means the best action now would be to advise him to reconsider surgery because greater than 30% of the patients do require repeat surgeries, apprise him what the guidelines recommend and ask him to decide between the two options, give him information about all the available biologics and asking him to choose one, letting him know all his therapeutic options and the pros and cons of each. So if you'll submit your answer, please. Okay. So like I said, we'll come back and go over those after we go through the post-test evaluation. But let's look at a case study. And here is Bob. Now, Bob's a 45-year-old male with chronic rhinosinusitis with nasal polyps. He also has asthma as a comorbidity. Now, he tells us his polyps have gotten worse over the last 2 years, and he's required multiple oral corticosteroid bursts in that 2-year period. He tells us that he's very compliant with his standard of care therapy, which is saline irrigation and intranasal corticosteroids. He tells us how his sleep quality and work productivity and his ability to do normal social activities have really been negatively affected related to his nasal polyp problem. And he's never had surgery for this condition. So if you were taking care of Bob, what additional information would you consider most important at this point? So would it be a blood eosinophil count and serum IgE, or a CT scan of the sinuses, nasal endoscopy, spirometry, or fractional exhaled nitric oxide? Now, all of these, in fact, are important, but the one that's important for assessment of his nasal polyps is, in fact, a CT scan of the sinuses or nasal endoscopy, because we need objective data as far as looking at the degree of nasal polyp problem. Now, the others are extremely important, again, related to his asthma comorbidity. But number B here would be the answer related to his nasal polyps. So let's look at an overview of chronic rhinosinusitis. And it is a very common condition in the adult population in the United States, where almost about 12% of the US population has the condition. Now, we tend to divide it up into two large groups, the groups with and without nasal polyps. The largest group is the group without nasal polyps, which makes up about 80% of the chronic rhinosinusitis population. And this is seen primarily in females over males. In contrast to that, we have the group with nasal polyps. Again, so therefore it makes up about 20%. And these patients tend to be primarily male compared to female. And we'll go into more details in a few minutes. It's important to realize that this is not just a condition that's seen in the United States, but in fact, it is seen worldwide. So this was a study by Klaus Backert that looked at prevalent studies throughout the world with chronic rhinosinusitis. And you can see, again, the highest rate here was the US, but again, you can see high values here in Europe and in China. So in other words, it is a problem that in fact is seen worldwide. Now, one of the things I think all of us know that if cared for patients with chronic rhinosinusitis with nasal polyps is the high medical cost associated with the condition. So this study that was in Laryngoscope in 2019 looked at claims-based data in over 21,000 patients, half approximately with chronic rhinosinusitis nasal polyps, the other half without. And the data was looked at primarily from about 2010 to 2015. And if we look at the bar graph and we look at total cost, you can see here in the blue, the costs were dramatically higher in the group with chronic rhinosinusitis compared to the group with placebo, who did not have the condition. And you can see the incremental cost, or the IC there, is about $11,500. And you can see the p-value. And if we look at pharmacy cost and medical cost, office visits, ambulatory cost, again, they're all significantly higher in the patients that in fact had chronic rhinosinusitis with nasal polyps. So let's look at our diagnostic criteria and also understand the common comorbidities that we can see with this condition. So this is the recommended diagnostic criteria, and we talk about the clinical criteria, and you have to have 2 or more of these symptoms for 12 weeks or greater. So as you can see here, mucopurulent drainage, nasal congestion, facial pain, pressure, fullness, and decreased or loss of sense of smell. And 1 or more of the objective findings, which again include endoscopy. So you want to confirm that there's drainage, there's mucosal edema, obviously, are there polyps or not? And then a CT scan to really look at the degree of inflammation seen in the paranasal sinuses. So if we look at the disease burden, and I think that, again, patients with and without nasal polyps have, again, the same symptoms, but they don't seem to be in the same order. So we look at our patients without nasal polyps, they tend to complain more with nasal obstruction and a lot of purulent secretion and facial pain. When we look at our patients with chronic rhinosinusitis nasal polyps, not uncommonly the major problem they complain about, much like we heard with Bob, is loss of smell. And again, the other symptoms can definitely occur. And if we look over at the right at the CT scan, again, we can see the normal sinuses and the control. In the patient with severe chronic rhinosinusitis nasal polyps, you see almost complete opacification of all the paranasal sinuses. And below with endoscopy, we can see normal endoscopy. You can see the inferior turbinate there, nice and pink. But in the patient with severe disease, again, you can see the several different polyps that are coming out toward the inferior turbinate there. So how do we define uncontrolled and severe chronic rhinosinusitis with nasal polyps? So this comes from a recent update by EUFOREA. And if you're not familiar with EUFOREA, this is a group of clinicians and academicians that are part of the European Forum for Research and Education in Allergy and Airway Diseases. And so lots of otolaryngologists and allergists make up the group of EUFOREA. And so their definition for uncontrolled chronic rhinosinusitis with nasal polyps, as you can see here, is persistent or recurring disease despite long-term intranasal corticosteroids and having received 1 or more courses of oral steroids in the preceding 2 years and or previous sinonasal surgery. So if we go back and think about POB that we talked about, Bob definitely fits this criteria for uncontrolled chronic rhinosinusitis with nasal polyps. If we look at severe, this is bilateral disease with a nasal polyp score of 4 or greater. We'll talk about that in a little while because it is a major criteria. And usually polyps are scored from 0 to 4, 0 being no polyps, 4, in fact, coming out the nostril. And then it's scored on both sides. So the highest score would be an 8. So again, we're talking about a score of 4 or greater and persistent symptoms despite long-term intranasal corticosteroid with the need for add-on treatment. Now, we haven't done endoscopy on Bob at this time, but with his problem, especially needing so much steroids and loss of smell, there's no doubt that he probably has a nasal polyp score of 4 or greater and probably, again, would qualify as having severe disease. Now, what about comorbidities? So this is an interesting study by Bautre et al. That comes to us from out of the University of Texas Southwestern. These were patients that referred to that university and other academic otolaryngology groups throughout the country for revision surgery for their chronic rhinosinusitis. And what we're seeing here is looking at comorbidities depending upon whether or not they had polyps or not. So you can see the first group here, aspirin or NSAID exacerbatory respiratory disease. None of the patients without polyps had it, but you can see over 25% of the group with polyps. And then if we look at asthma and allergic rhinitis, you can see here that the group with polyps had much higher levels of these two comorbidities than the group without nasal polyps. One of the things that I think is extremely important to remember is that, in fact, when patients have nasal polyps with asthma, both conditions, in fact, tend to be worse and harder to get under control. So a couple of examples of that is first on the left, this is a study out of Montreal that looked at asthma patients with and without nasal polyps. And what you'll notice here is the group with nasal polyps, they tended to be older, they had poorer lung function, higher levels of sputum and serum eosinophils, higher needs for inhaled corticosteroids, and poorer asthma control. And on the right, on the bar graph, this comes from the Severe Asthma Research Program out of the NIH, and they looked at the association in adult patients between nasal polyps and asthma exacerbations. And as you can see here, the group with 3 or more exacerbations in a year had a significantly higher number that had nasal polyps compared to the group none or 1 to 2. So again, that relationship, when you have these two conditions together, you tend to have more severe disease. And one of the conditions we see that really leads to severe disease, if those patients have the comorbidity of aspirin or NSAID exacerbatory respiratory disease. And studies suggest anywhere from 30 to 40% of patients with chronic rhinosinusitis with nasal polyps and asthma do have this condition. Why this is so extremely important to recognize is that these patients really have severe disease. These are some of the most severe asthma patients we see. They tend to be very hard to control. They tend to end up not uncommonly hospitalized in the intensive care unit and even intubated. They have an increased risk of death associated with their asthma. And they have, again, very severe inflammation of their lungs. And to match that, they also have very severe disease with their chronic rhinosinusitis with nasal polyps. They tend to have hyperplastic pansinusitis. The eosinophils are full of, the nasal polyps are full of eosinophils. They have high mucus production, very large polyps, and again, a very high rate of decrease or loss of sense of smell. Now let's look a little bit in the immunology here. So we're going to look at the inflammatory endotypes and chronic rhinosinusitis with nasal polyps pathophysiology. So we can divide this into 3 different endotypes for chronic rhinosinusitis. So type 1 disease, where again, we're very familiar with the Th1 cell and the NK cell. and the primary cytokines involved in type 1 disease, interferon gamma and IL-12. These patients primarily do not have nasal polyps. They tend to have a lot of congestion and purulent drainage, and they tend to be much higher seen in the female population compared to the male. Type 2 disease, we have very familiar cells like the Th2 cell, the type 2 innate lymphocyte, the eosinophil, the mast cell, and we know that this can be driven by the type 2 cytokines, IL-4, IL-5, and IL-13. So these patients have a very high rate of nasal polyps and asthma. As we mentioned, they tend to have the decrease or loss of sense of smell. And again, this is primarily seen with nasal polyps, but it doesn't have to be. And there are patients with chronic rhinosinusitis without nasal polyps that have type 2 disease. And the third group, which tends to be the least group that we see, are the type 3 disease, primarily associated with the Th17 cell and the neutrophil, with the cytokines primarily involved here being IL-17 and 22. These patients tend to have more purulent drainage, but there is a group here that does have nasal polyps, and this tends to be very high in the Asian community, where type 2 disease with nasal polyps is seen, again, very high in the Caucasian and the African American population. Now, if we take the two major phenotypes here, with and without nasal polyps, the group without nasal polyps, again, is primarily type 1 disease. And if we look at comorbidities, again, we do see asthma and allergic rhinitis. But if we look at the group with polyps, which in fact is primarily a type 2 disease, you see much higher levels of type 2 comorbidities like asthma and allergic rhinitis. And as we mentioned, aspirin or NSAID exacerbatory respiratory disease. Now, it's important to understand the role of the type 2 cytokines as they are key as far as driving the disease associated with chronic rhinosinusitis with nasal polyps. So we need to start with that epithelium barrier, the activation of it, and the dysfunction. So we know that it is bombarded by allergens and viruses and bacteria. We especially know in chronic rhinosinusitis with nasal polyps that many of these patients have bacterial colonization with Staph aureus. But we also know there are abnormalities of the epithelium, and that we know that there are abnormalities of the tight junction proteins that bind the epithelial cells together. We may see abnormalities or deficiencies of flagellin, which again allows for the allergens and irritants to penetrate more. Also in the epithelial cells, when they in fact are damaged, activated, we can have the release of epithelial alarmins. Those include TSLP, IL-25, and IL-33, and they also can drive type 2 inflammation. Now, if we look at the allergic pathway, we know that in fact we have the T null cell, that if it's in an environment with IL-4, it will present antigen to and become a Th2 cell. That Th2 cell releases IL-4 and IL-13 that binds to the IL-4 or alpha receptor on the B cell. This stimulates the B cell to become a memory B cell, a plasma cell that produces a specific IgE. Now, in chronic rhinosinusitis with nasal polyps, we do see, in fact, Staph aureus can lead to superantigen, can lead to activation of B cells, and we can get local production of IgE to Staph aureus. That IgE then can bind to mast cells and basophils, and when it's re-exposed to that particular antigen or allergen, the mast cell can literally explode. One gets the release of hundreds of different mediators, histamine, prostaglandins, leukotrienes, and we also get a positive feedback of the type 2 cytokines. We also know the very important role of eosinophils here in eosinophilic inflammation. In the bone marrow, IL-5 is key to leading to differentiation of stem cells to eosinophils, and also is very important for the eosinophilic survival through the circulation. Once it gets to the target organ, in this case the nasal sinus tissue, We get activation by the type 2 cytokines 4, 5, and 13. We get upregulation of adhesion molecules, and we get chemotaxis of the eosinophils into the nasal and sinus tissue. And very importantly, we're starting to understand more and more the role of IL-13 and its effect here. Very important on those epithelial cells. It does lead to goblet cell hyperplasia and increased mucus secretion, which leads to problems. And also, we get activation of fibroblasts, leading to increased collagen production and can lead to effects as far as polyp formation. So it's very important to understand how these cytokines then lead to the active disease that we see in our patients with chronic rhinosinusitis with nasal polyps. So now let's return to Bob here. So we mentioned Bob's a male, he's 45 years of age, he has chronic rhinosinusitis with nasal polyps. He's gone through 2 courses of oral corticosteroids within the last 2 years. Now, we also said he has asthma as a comorbidity, and that's important. And if we look at his lung function, it shows his predicted FEV1 is 68% of normal with 17% reversibility. So he definitely has asthma, and it's obviously not under optimal control. He has an increased fractional exhaled nitric oxide at 35 parts per billion, even though he's on high-dose inhaled corticosteroids, long-acting beta agonists. Now, he tells us he doesn't have any problems using aspirin or NSAIDs, and he's already told us that he's been compliant with his nasal saline irrigation and intranasal corticosteroids. So we get to the next question I want to pose to you, and that is, what treatment would you recommend for Bob right now? Would it be functional endoscopic sinus surgery? Would it be a biologic treatment? Would it be exhalational delivery system fluticasone, or alternate day oral corticosteroids? And to be honest, any of these treatments, fall under guidelines as far as treatment of this condition. Obviously, some are safer than others, but nevertheless, and as we'll talk about it, it'll be important for Bob to understand all these treatments and that we can come to a shared decision. So let's talk about the medical management of our patients with chronic rhinosinusitis with nasal polyps. And first is standard of care therapy, what we start all these patients on when we first see them for their nasal polyps. And again, we mentioned, as for Bob, a saline irrigation, and studies have shown that large volume hypertonic saline probably works the best. Low volume's not very effective. And then all patients need to be placed on intranasal corticosteroids. As we know, many of these are over the counter or generic. We do not have any approved nasal drops, steroid drops in the United States as there are in other countries, though there is off-label use with things like budesonide. And then oral corticosteroids, where we may in fact give patients like Bob, which he had done, a medical polypectomy. In other words, a short course of oral corticosteroids to give him relief from his severe blockage and problems with his loss of smell. Obviously, we want to keep that to a minimum. Unfortunately, I think all of us realize that standard of care medical management doesn't work for all patients. There's a lot of failure that is seen with the use of these treatments. So another treatment that's approved is exhalational delivery system with fluticasone, which again is a intranasal corticosteroid. And with this device, it's sprayed into the nose, as we see here, so it gets to the posterior sinus cavity. So if we look at the drawing here, you can see the device itself. You have a mouthpiece and a piece that in fact goes into the nose. So in fact, what you do is you blow into the mouthpiece. That then leads to your soft palate closing. Then you spray the medication. And with the soft palate closed, that increases pressure in the sinuses and allows more of the medication to get deeper into the sinus cavities. It was approved in a phase 3 study by the FDA in 2017. In their study, they looked at patients with moderate to severe chronic rhinosinusitis with nasal polyps. They found that it eliminated polyps in 25% of the patients on at least one side, compared to only 8.7% with the placebo spray. They also used the Sinonasal Outcome Test 22, which looks at symptomatology and quality of life related to sinus nasal disease. They showed significant improvement and also a significant decreased need for surgery. Which leads us to surgery, and that is functional endoscopic sinus surgery. That's the most common surgery done in the United States for chronic rhinosinusitis with nasal polyps. So what's its pros? It does lead to rapid relief of symptoms, has a very high success rate as far as removing the polyps. And generally, this is a minimally invasive procedure compared to conventional sinus surgery, where in fact here you're removing the polyps, opening up the ostia, but you're not scraping out the sinuses or making them somewhat larger, which again is more conventional sinus surgery. So with this minimally invasive type of surgery, patients tend to heal more rapidly. They tend to have shorter recovery time so they can get back to work. It can be done on an outpatient basis, and in general has fewer complications. But there are definitely cons, and patients need to know that nasal polyps can definitely regrow, that they must go back on intranasal corticosteroids to prevent regrowth of polyps. And unfortunately, our patients that have significant type 2 disease with this, they tend to have a very high rate of recurrence of polyps. And again, all surgery can have some complications. It's seen about 5% have some minor complications, a very small percent have major. Now, we talked about standard of care therapy, as you can see in the arrow. So a study that was done in Europe, which was part of the Global Allergy and Asthma European Network, looked at patients that were being treated with standard of care therapy and determined that over a long period of time, about half, in fact, eventually required surgery. So about 50%, in fact, failed on standard of care therapy. And then there have been studies, again, primarily in Europe, the first one here, looking at reoccurrence after surgery. And it was about 20 to 35% of the patients at 6 months and 40% of the patients at 18 months. And then an interesting studies out of the UK looked at long-term outcomes of patients that have had sinus surgery. And about a third required repeat surgery over a 12-year period. And 20% of those patients required multiple surgeries. Because again, and as we mentioned, surgery doesn't cure the condition. Another treatment that can be used after patients have had surgery for their nasal polyps, but they've reoccurred, is in fact steroid-eluting stents. And these, again, are approved for patients 18 years of older who have already had a previous sinus surgery. This uses mometasone. It's delivered to the ethmoid sinus over a 90-day period. The good news, this can be placed by an otolaryngologist in the office. And their phase 3 study looked at patients that had had previous surgery and received the stent. And it showed that there was significant reduction in nasal congestion and obstruction. And basically almost 2/3 of the patients had a reduction in the need for revision surgery. So this is an option in patients that have failed previous surgery. And the next group of drugs I want to talk about are the biologic treatment options. And the question we have to ask here when we're evaluating a patient, do they meet criteria for the use of biologic treatment? So this again comes from the group out of Europe, EUFOREA, and they looked at their guidelines for indications for biologic treatment in patients with chronic rhinosinusitis with nasal polyps. One is it needs to be bilateral disease. When it's unilateral, we have to think of other conditions. I know in children, we always think about things like cystic fibrosis. And then it's divided up here whether they have had surgery for their sinuses or not. And then they looked at five criteria. If they've had surgery, they have to meet 3 of these criteria. If they've not had surgery, they have to meet 4 of these criteria out of 5. So what are the criteria? And you can see them on the slide. You need to see evidence of type 2 inflammation, the need for systemic corticosteroids over the past year, significant impairment of quality of life and significant loss of smell, and a diagnosis of comorbid asthma. So let's think about our patient Bob. And if you think about Bob, when he hasn't had surgery, so he needs 4 of these. And in fact, there's no doubt from what we've found from Bob is, in fact, he meets all 5 of these criteria. So he definitely is a candidate for biologic treatment. So what I'd like to do now is go over with you the FDA approved and emerging biologics for chronic rhinosinusitis with nasal polyps. And this table goes in the order in which they've been approved by the FDA. So first is DUPILUMAB, which we know blocks the IL-4R alpha receptor. Therefore, it blocks the action of IL-4 and IL-13. As you can see, it was approved in June of 2019. And the indication is add-on maintenance for adults with uncontrolled chronic rhinosinusitis with nasal polyps. You can see that it's dosed at 300 milligrams every 2 weeks. And we'll discuss the phase 3 studies for these products in just a minute. OMALIZUMAB is next. It blocks, as we know, IgE, was approved in December 2020. And its indication is add-on maintenance for adults with an adequate response to intranasal corticosteroids for nasal polyps. Now, it's dosed as we dose in asthma. So it's based on the patient's body weight and serum IgE level. So the dose is anywhere from 75 to 600 milligrams every 2 to 4 weeks. Again, this is sub-Q, as is DUPILUMAB. And then the third one that was just recently approved by the FDA, that is mepolizumab, which blocks IL-5, was approved in July of this year, has the same indication as omalizumab, and it's given at 100 milligrams every 4 weeks sub-Q. And there's another product right now that is in studies, and that's benzorilimab. You can see its mechanism of action blocking the IL-5R alpha receptor, and it'll be dosed, if approved, every 4 weeks at 30 milligrams. So now, in all of these studies, and this goes with FDA criteria, there are 2 co-primary endpoints that have to be met. The first co-primary endpoint is looking at NPS, or nasal polyp score. And you can see here the grading of nasal polyps from 0 to 4. You can see 0 being no polyps, all the way to 4, which is large polyps causing complete obstruction of the inferior nasal turbinate. So the highest score would be an 8. In these clinical studies for approval of the biologics, these patients had scores of 5 or greater. And in the second co-primary endpoint, that is the nasal congestion score. So this is a subjective measure of the patient reporting their symptom severity related to nasal congestion and obstruction over a 24-hour period. And you'll notice the scale here is from 0 to 3, 0 being no problems, to 3 being severe. And that's described to the patient as symptoms that are difficult to tolerate and cause interference with activities of daily living. Now, 2 of the studies that we'll show did the 0 through 3 scale. The last study I'll show, in fact, it was a 0 to 10 scale. But nevertheless, these are the 2 co-primary endpoints. Now, all of these studies I'm going to show you looked at many other parameters like smell. They looked at quality of life and other issues. So it's important to know that also. But we're going to look at primarily the co-primary endpoints and some other data related to these studies. So the first one I want to mention are the phase 3 studies for DUPILUMAB. They had 2 studies, which was the nasal polyp sinus 24 and the nasal polyp sinus 52. So the 24 was giving DUPILUMAB every 2 weeks for 24 weeks versus placebo. Now, in all of these studies, all patients stayed on an intranasal corticosteroid. In the nasal polyp, in the sinus 24, primary endpoint was at 24 weeks. And then the medications were stopped and the patients were followed. And then in the sinus 52, again, DUPILUMAB was given every 2 weeks or placebo until week 24. And at week 24, the group on DUPILUMAB half stayed on every 2 weeks and the other half went to every 4 weeks to see if there was any difference. So first, let's look at the nasal polyp score. And I think one of the interesting ways to compare these studies is looking at improvement at greater than 2 points, again, out of that 8-point scale. So if we look at sinus 24, there was a 46% improvement with DUPILUMAB versus 5% with placebo, obviously statistically significant. And in sinus 52, 2-point or greater, it was 46% again in the patients with DUPILUMAB and just 1% in the group with placebo. And as you can see on the top here for nasal polyp score for 24 and 52, the graphs, again, you can see the significant improvement with DUPILUMAB. And again, when you look at 52 weeks, as far as nasal polyp score, there really wasn't any difference as far as the outcome here between the group that was now on every 4 weeks DUPILUMAB versus every 2 weeks. Though again, only every 2 weeks has been approved by the FDA. And if we look at the bottom, looking at nasal congestion score, remember we said that the score was from 0 to 3. So if we look at sinus 24, in fact, there was a 0.89 improvement or decrease in congestion with DUPILUMAB compared to placebo, which was statistically significant. And in sinus 52, it was a 0.87 out of the 3-point. So again, another significant improvement, this time, again, with nasal congestion seen with DUPILUMAB. Now, one of the more interesting things looked at in this study was looking at the ability of DUPILUMAB to reduce the need for oral corticosteroids or the need for repeat or first-time sinus surgery. So this is looking at a pooled analysis for both sinus 24 and sinus 52. And so if we look at 52 weeks, we can see here the placebo group either required oral steroids or surgery. It was in 41.8% of the patients, where it was only 12.5% of the patients who received DUPILUMAB. And if we look at safety profile, we see, again, high safety profile that we've seen with DUPILUMAB and other conditions, with nasal pharyngitis being the most common. You'll notice that nasal polyps, again, in the placebo group as a adverse event was much higher than in the DUPILUMAB group, and the same for asthma worsening. Now let's move on to OMALIZUMAB. So they did 2 phase 3 clinical trials, both looking at 24 weeks. So the first we're looking at here is with nasal polyps. And if we look at their data as far as a 2-point or greater improvement, it was 31% of the patients on OMALIZUMAB versus 11% of the patients on placebo, which in fact was statistically significant. And again, you can see here the point difference here between OMALIZUMAB and placebo for both of these POLYP 1 and POLYP 2 studies. And if we look at nasal congestion score, we see that with POLYP 1, there was in fact a difference compared to placebo of 0.55, again, out of that 3-point scale, which was statistically significant. And in POLYP 2, it was a 0.5 difference, which again was statistically significant. So again, it met both endpoints as required by the FDA. Now, if we look at safety associated with omalizumab, we know that this agent has been around 17 years, so we're very familiar with the safety of this particular product. And again, not surprising, you see here that asthma exacerbation worsening was was much higher in the placebo group than the omalizumab group. And again, we see the high rate of nasal pharyngitis. So again, a very high safety profile. And the third agent is mepolizumab. And this again comes from their phase 3 trial called Synapsis. And again, this is looking at the co-primary endpoints. It's looking at it a little differently here than we saw in the other two studies. But what we're looking at here is whether the patients had, if we look first over at the left, as far as looking at nasal polyps, worsening, no change, and then point improvements. And you can see in the red here is mepolizumab, and the gray is the placebo group. This was looked at 52 weeks. So a little different than what we talked about as far as dupilumab and omalizumab, though dupilumab looked at both 24 and 52 weeks. If we look at 2-point or greater improvement, if we add that up here, it was about 36% of the patients with mepolizumab and 12%, in fact, of the patients on placebo. So again, they did show a significant improvement at 52 weeks as far as nasal polyp score. And then if we look over at the right, they're looking again at a 10-point change as far as nasal congestion score. And you can see here, again, comparing mepolizumab to placebo. The bottom line here is that there was, again, a statistical significant improvement in nasal obstruction at 52 weeks in the mepolizumab group compared to the placebo group. Now, they also looked at mepolizumab as far as its efficacy, as far as reducing the need for surgery. And in fact, what they found, as we see here, that about 9% of the patients on mepolizumab required surgery versus 23% of the patients on placebo. And you can see that that was a statistically significant difference. And again, a very high safety profile with mepolizumab, with the most common adverse event being nasal pharyngitis. Now, there was one treatment related event, which was a TIA, which occurred in the placebo group. And then there was a patient that died from a myocardial infarction in the follow-up period, but that was also in the placebo group. So again, a very high safety profile also seen with mepolizumab. So how do we go about choosing a biologic, and how do we go about using shared decision making? So this again comes from EUFOREA, and this is selecting a biologic. And very importantly is what you see in the red here, and that is predicting response in any individual patient is not yet possible. So we can't tell you which biologic is really best for which patient with chronic rhinosinusitis with nasal polyps at this time. But patients that would qualify, we need to confirm that they have a diagnosis of uncontrolled severe chronic rhinosinusitis nasal polyps. We need to check, see if they have any of the type 2 comorbidities. So we want to make sure that, in fact, that there's a high likelihood that these patients truly have type 2 inflammation. Patients need to be informed of the treatment options, perspectives, and risk, which gets back to shared decision making. And therefore, we work with them to make a decision on whether it should be surgery or a biologic. And then we select the biologic treatment. Again, there may be certain limitations. We know, especially related to payers out there, as far as which ones may be able to be used in a particular patient. And again, if that patient also has asthma, obviously correlation of this with an asthma specialist is extremely important. So we put a patient on one of the biologics, and this talks about assessing that patient after 6 months of treatment. So what we're looking for here is improvement of at least one symptom or score. So improvement in sense of smell, or nasal congestion score, nasal polyp score, or SNOT-22, or using a visual analog scale, So seeing that there's at least some improvement over a 6-month period. If the answer is yes, and the improvement is acceptable to the patient, we'd continue that same biologic. If the improvement was not acceptable to the patient, then they suggest maybe a short course of oral corticosteroids and maybe doing surgery under biologic protection. If the answer is no after 6 months, then either change the surgery or switch to a different biologic drug. Now, what about after 12 months? After 12 months, you really should see really adequate response, significant improvement in our patients. So improvement in polyp size and congestion, improvement in the SNOT-22, no need for oral steroids, no need for surgery. If the answer to that is yes, we continue the biologic therapy because, again, it doesn't cure the condition. None of the treatments we have, as we know, for chronic rhinosinusitis with nasal polyps cure the condition. The answer is no, we either go to surgery or another biologic drug. So this leads to shared decision making. And again, what are some of the things we need to think about that are options as far as shared decision making in our patients with chronic rhinosinusitis with nasal polyps? So if they fail standard of care, we could talk about a biologic or fluticasone breath-powered exhalation device or a surgical procedure. If they've had failure from their first or second or third surgical procedure, then it would be between a biologic, an in-office corticosteroid-eluting stent, or another surgery. And what Bob kind of falls in, which is number 4 here, if they fail standard of care therapy and have concomitant type 2 disease, like type 2 asthma, then shared decision making probably makes sense between a biologic and a surgical procedure. Now, this is a kind of a modified shared decision making tool for a patient. This is from a shared decision making tool that's been developed by the American College of Allergy, Asthma, and Immunology and the American Rhinologic Society. And the bottom line is to give information to patients in a way they can understand it, talking about how the particular treatment's used, its pros, its cons, its cost, what should the patient expect as far as improvement with the treatment. And then by using tools like this, one can then talk with the patient and determine what fits best for them for their particular condition. So, coming back to our friend Bob, he has uncontrolled severe chronic rhinosinusitis with nasal polyps with asthma comorbidity. So shared decision making, again, would be between surgery and one of the biologic treatments. So again, we need to assess from Bob his values and preferences. So we may talk about surgery, but he may not want to undergo it. He's worried about time missed from work. DUPILUMAB, he knows it has the longest track record for treatment of polyps. The dosing's every other week. OMALIZUMAB, the dosing's every 2 to 4 weeks after we see what his IgE level is. And mepolizumab hasn't been around as long for polyps. The dosing is every 4 weeks. So he needs to look at that and obviously would look at cost issues also. So in summary, we said that chronic rhinosinusitis, we mentioned, is highly prevalent and with nasal polyps, and it accounts for about 20% of patients that have chronic rhinosinusitis. We talked about the different comorbidities that we see in our patients with polyps, asthma, allergies, NSAID, aspirin, exacerbatory respiratory disease. We talked about this being driven primarily by type 2 inflammation and the type 2 cytokines 4, 5, and 13. We talked about medical management, but there's definitely a degree of failure associated with it. We know that functional endoscopic sinus surgery definitely can be successful, doesn't cure the condition, and especially patients with type 2 disease have a high reoccurrence. Presently, we have 3 biologics that are approved for chronic rhinosinusitis with nasal polyps. It's important to use shared decision making. We need to understand our patients' goals, dosing preferences, insurance, and ability to pay to make the decision of which one would be best for which particular patient. So with that, we're going to move on now to our post-test polling. So the first one, the primary cytokines involved in type 2 inflammation. The most common endotype in patients with chronic rhinosinusitis nasal polyps are. And if you'll submit your answer now. And the answer, in fact, if we can go back for just a second, maybe not possible, but the answer again was IL-4, IL-13, IL-5. Which biologic showed improvement in nasal polyp score 2 points or greater in half the population, 24 and 52 weeks? And in fact, it was DUPILUMAB. Which is the most commonly observed treatment emergent adverse event across clinical trials of all the biologics studied for chronic rhinosinusitis with nasal polyps? Yes, in fact, it was nasal pharyngitis. Mr. Brown, a 42-year-old male patient with severe chronic rhinosinusitis with nasal polyps, returns 12 months after endoscopic surgery, complaining persistent symptoms. You suspect his nasal polyps have regrown as far as type 2 inflammation, and the Z scoring system shows some improvement, but did not meet EUFOREA criteria for adequate response. What does EUFOREA recommend now? And in fact, it would be a biologic drug or revision surgery. And the last question, feeling discouraged, Mr. Brown says if the nasal polyps are just going to come back anyway, doesn't want to go through all the expense, pain, and downtime of undergoing surgery again. Shared decision making means the best action to do now would be, and in fact, it is the last answer there, letting him know all his therapeutic options, the pros and cons of each. In other words, let him understand first and then have a discussion with him to come up with the best now solution for his problem. So with that, I think we'll move into Q&A, question and answers. Well, I don't see any questions at this time. Oh, here comes one. What are some of the reasons patients give you for choosing a biologic over surgery or vice versa? And I think that is a very important question. Obviously, a lot of patients don't want to go through surgery because it's not going to cure the problem. So they don't want to take that risk and miss the time off of work. So I think that becomes one of the main reasons that patients, in fact, decide they don't want to do surgery. I think as far as the biologic concern, for so many of the patients, as we've talked about, that have chronic rhinosinusitis with nasal polyps, they also have asthma. And as we know, all three of those biologics we talked about are approved for asthma. So it really allows us, and I think patients like this, to be able to treat two conditions with one medication. So I think that's one of the real advantages of using biologics in these patients with type 2 disease. So we have one more question. Do you have any tips for clinicians to help ensure the cost of biologic is covered by the patient's insurance? So I'll tell you what I do. We really have to get in touch with their insurance company and get an idea as far as which products, in fact, may be preferred on their particular insurance plan, and then what, if any, copay that patient would have. And so once we can get that information, then we can get the patient to give the patient that information to help them decide if, in fact, this is something that they, in fact, can afford to have done for their condition. So obviously, sometimes we get the patients to do that on their own, or they have done it. Other times we'll have our insurance people do it. But I do think that obviously that's extremely important to do, to try to find out what their coverage is for the different biologics to make that decision. And then once that's done, obviously we're always going to have to submit prior authorization to get approval for the use of the biologic. I think that's the last question. So again, I want to thank you for joining me this evening. Hope you found that this was valuable. And for additional resources, information related to the subject, you can go to integrityce.com/CRSWNP resources. Now, you'll be redirected now to do the evaluation, or you can claim your CME credits by going to integrityce.com/chronic rhinosinusitis with nasal polyps, CRSWNP, post eval 8. So